Hey everybody, welcome back to Patho-Mnemonic. For those of you who are new to this, my name is Peter. I'm a fourth year med student at Case Western. This is an NBME Shelf exam and Step 2 CK content review series. Each episode I try to keep within the scope of a single shelf exam, and then all of them fit within the window of Step 2 CK. So in this episode, we'll be returning to content that you'll probably see on your surgery shelf exam. I know episode 1 was probably my most popular video and the most requested for episode 2, so I figured I would come back. Um, so thank you for waiting. But without further ado, let's go ahead and get started. Um, so we'll start off with blood transfusions and the reactions that are associated with them. So we'll just go through some rapid fire scenarios for each type of blood transfusion. Let's say, for example, there's a patient that has a blood transfusion and develops sudden onset shortness of breath, pain at the IV site, complains of back or flank pain, has jaundice, and then has dark urine, or it has hemoglobinuria on urinalysis. So you'll need to know the diagnosis of what this is, which is an acute hemolytic transfusion reaction, right? Sudden onset hemolytic because jaundice and hemoglobinuria, and then it's a transfusion reaction. You'll also probably need to know the etiology of these different types of blood transfusions. Like, it might not say what's the diagnosis. The question might ask you, what is the etiology? So in this case, it is preformed antibodies to donor red blood cells causing hemolysis. So this is really like where you get into the territory of ABO mismatch, or like the clerical error, where someone who is type A gets like type B blood or something like that. Um, the management of this kind of transfusion reaction, which is in common with the other transfusion reactions, is you stop the transfusion immediately and you give supportive care. So, like if you need to intubate, you'll intubate fluids, so on and so forth. But the most important thing that you need to know is to stop the transfusion. And then you'll also see sometimes you have to contact the blood bank and to make sure that this doesn't happen again, because this is a very dangerous situation. Okay, so this other scenario, the patient also becomes jaundiced, but that's kind of their only symptom, and it happens a few days after receiving a transfusion. So again, what is the diagnosis in this case? This is a delayed transfusion reaction, and the etiology of it is the buzzword you'll probably see is a delayed anamnestic response, which is just a response to foreign antigens that the patient was previously exposed to. So let's say, for example, they had a transfusion a couple, I don't know, months or years ago, or they had like a hematopoietic stem cell transplant, so on and so forth. Anything that gave them foreign antigens that then they made antibodies to that aren't ABO antibodies. Um, so the reaction is a little bit milder. The management of this delayed transfusion reaction, nothing crazy. Like sometimes you'll see the vignette where they come to the outpatient office for a follow-up visit after an inpatient admission for like a motor vehicle collision and they had a bunch of transfusions, and then they come to the the outpatient office a couple days afterwards and they're jaundiced, but otherwise they're doing fine. So you don't need to do anything. Um, on the side of caution, you could do serial monitoring of hemoglobin because it still is hemolysis, and if you're destroying red blood cells, then you can cause anemia. Um, and then you also want to avoid whatever antigen that they were exposed to. You want to avoid that in future transfusions. But for the sake of tests, um, you don't have to do anything crazy for these kinds of patients. Okay, continuing with blood transfusions. Let's say, for example, someone is like in the emergency room and they're getting a transfusion, and then they get itchy, and you take a look at them and they have hives all over their skin, but otherwise they're fine. So the diagnosis or this kind of blood transfusion reaction is just an allergic reaction. The etiology of it is a type 1 hypersensitivity reaction, if you remember that from preclinical, like step 1 stuff, which is basically preformed IgE antibodies that then cross-link with antigens in the transfusion, and then that stimulates histamine release, and that histamine is what causes the itching and the hives. Um, A little side note, the way that I remember the type 1 hypersensitivity reaction is it's immediate, and the E in immediate is IgE. That's how I remember it. Um, anyway, the management of this kind of transfusion reaction is, again, like we've seen before, you pause the transfusion, plus or minus give them diphenhydramine to help with the itchiness and the hives. And then if that's better, then you can continue the same transfusion. And if symptoms recur, then you can give additional doses of diphenhydramine. Um, yes, okay. So let's say, for example, a different patient is also getting a transfusion and they develop a rash, they start coughing, they become hypotensive, tachycardic, and they start swelling. The diagnosis in this case is anaphylaxis from an immune response to donor immunoglobulins. Um, so again, like the foreign antigen causing an immune response, and then um, you have this really severe response, so it causes anaphylaxis. Or in this case, since it's hypotensive tachycardic, if you get into the realm of organ dysfunction, that's where you get into shock, and that's where you get into anaphylactic shock. So you'll see things like elevated LFTs, neurodysfunction, oliguria, so on and so forth. Um, the risk factor or the common associated comorbidity or pre-existing condition that's associated with this type of anaphylaxis to um, blood transfusions is IgA deficiency. So if a patient has IgA deficiency, this is like a common thing that they'll ask you about, where it's like an association between IgA deficiency and anaphylaxis from blood transfusions. Because, like, let's say, for example, the patient has IgA deficiency, they're obviously not making IgA antibodies. And so, kind of ironically, well, if they get a blood transfusion and that blood transfusion has IgA antibodies in the blood, the patient's immune system doesn't recognize, or it recognizes, it doesn't, it's never seen IgA before, so it mounts an immune response and then you get anaphylaxis. Okay, the management of anaphylaxis to blood transfusions, again, similarly to before, you stop the transfusion. But since this is anaphylaxis, you can treat it very similarly to anaphylaxis to anything else like peanuts or bee stings or things like that, where you give an EpiPen or IM epinephrine, IV fluids in this case because hypotensive tachycardic, and then supportive care. In this case, you'll want to make sure the airway is maintained appropriately. I think in the first surgery episode, I mentioned indications to intubate, and I also talked about it in neuro. But, let's say, for example, this patient, you probably think about like the GCS, like the Glasgow Coma Scale or score. If that's less than 8, then you need to intubate. This patient might have an adequate GCS, but if their throat is closing off because they're so swollen, that's another indication to intubate. So I'm just reiterating that here. Okay. Let's see. Continuing with blood transfusions, there are a lot of reactions, but we're getting through them. Let's say, for example, a patient is getting a transfusion and they have fever, chills, dyspnea, but otherwise they're clinically stable. So the diagnosis in this case, if you can think about it, is a febrile, because they have a fever, non-hemolytic, because they're not jaundiced, transfusion reaction. So the etiology of this reaction to transfusions is preformed cytokines that accumulate in storage that are just activating the immune system in the recipient. So, you get blood, you store it, and then cytokines are released by the white blood cells or, whatever. And then once they go into the patient, the cytokines are just kind of floating around there, and then they activate the immune system. You get fever, chills, and dyspnea, but you're stable. Um, the management of this reaction to transfusions, again, as we've seen before, you pause the transfusion, plus or minus add antipyretics just to manage the symptoms. Okay. Um, I've also seen like you can reduce the risk of this reaction from happening by like washing the blood transfusion to get rid of the cytokines. So you keep that in mind as well. Okay, so let's say, for example, a different patient is getting a transfusion and all of a sudden they get short of breath, their oxygen saturation tanks, they become hypertensive, so their blood pressure skyrockets, and they have crackles on pulmonary exam. So these crackles right here and the hypertension kind of give it away to me, but the diagnosis in this case is a TACO or transfusion-associated circulatory overload. And fortunately, in this case, the name of the diagnosis kind of elucidates the etiology of this reaction, which is pretty much they're getting too much fluid too quickly and then it overwhelms the heart. So it's like you can kind of think about it like heart failure because there's too much fluid, it's fluid overload, and then they get pulmonary edema. So that's why you see hypertension because they have so much fluid, and that's why you see crackles because there's pulmonary edema, hypoxia because you have VQ mismatch, and so on and so forth. Um, okay. The management of this transfusion reaction, as we've seen before, you stop the transfusion, and because they have so much fluid, you can give them diuretics to take off some of that fluid. Okay, very similar vignette, sudden dyspnea, hypoxia, but in this case, they have hypotension, and then again, they have rails, and they also have a fever in this case. May or may not have a fever. The diagnosis in this case, since we've already talked about TACO, it's the other one. It's TRALI, or transfusion reaction acute lung injury. And the etiology in this case is again a little bit different from TACO. It's an immune response, hence the reason why they might have a fever. But it's an immune response to inflammatory cytokines in the donor blood. And then there's pulmonary vascular permeability, and then there's non-cardiogenic pulmonary edema. So the big kind of distinguishing factor between TRALI and TACO is there's pulmonary edema in both cases, but in TRALI it's non-cardiogenic because it's like an immune response. It's kind of like almost like what's the oh my God, I can't think about it. The other acute lung injury that happens in sepsis. Why can't I think of it? Maybe I'll think of it later. Anyway, it's like the system-wide um, wow, that's really bothering me that I can't remember the name. It's on the tip of my tongue. Um, but anyway, you have the immune response and you have like systemic vasodilation and vascular permeability. So then you just have fluid leaking into free spaces. And then um, oh my God, ARDS, that's what I'm thinking of. ARDS. It's very similar to ARDS. Um, in that you have the fluid that's leaking out into the alveoli. I can't think of words today. My God. Into the alveoli. So there's just fluid there. And then that causes pulmonary edema. But otherwise, the heart is fine. So this is cardiogenic pulmonary edema in TACO, but in TRALI, it is non-cardiogenic pulmonary edema. Okay. And then, of course, the management of this reaction, TRALI, as we've seen before, stop the transfusion. You don't need to give diuretics because, again, it's not because of fluid overload. Otherwise, it's like supportive care. So diuretics for TACO and then supportive care for TRALI. Okay, so so we've moved on from blood transfusions to stuff in the colon. I might be a little bit biased because in my surgery rotation, I was on colorectal surgery and therefore saw a lot of colon stuff. But colon and like rectum stuff is also very high yield on the surgery shelf. So this is good to know anyways. So let's say, for example, there's a patient that comes to maybe the office or maybe the ED, and they have episodic abdominal pain. It's like crampy, and they have um, tons of diarrhea, flatulence. They have like fevers every now and then. They may complain of right lower quadrant pain. And then when you ask them about bowel movements, they'll be like, oh, I have to flush it multiple times. And I see like little oily things, like little oily bubbles almost in the toilet water. Um, and then on like this is usually like in the end stage, but you know, you might see perianal abscesses or fistulas. Um, you might also So on the topic of so that's what so the double flushing and the oily droplets in the toilet water, that's steatorrhea, which is basically fat that is not being absorbed in the body and then therefore is being excreted in the stools. So that's why you can see the oily stuff and it'll float. And because you're not absorbing fat, you won't absorb fat-soluble vitamins. So you won't absorb vitamin A, D, E, and K. So you can have some malabsorption from those vitamin deficiencies. Anyway, so the diagnosis of this kind of patient with the symptoms that I've described here is Crohn's disease. Um, and the thing that really gives it away is the fistulas. That's a very distinguishing characteristic in Crohn, which is like one of the subtypes of inflammatory bowel disease. So one other thing that you'll need to know about Crohn disease, or it's helpful to know about Crohn disease, is the anatomic progression, because that can help you distinguish between Crohn and ulcerative colitis. Is it starts, well, actually, it can happen anywhere in the GI tract, anywhere from the nose to the anus, can be affected by Crohn disease. And you can have skip lesions, so you can have Crohn flares in like the esophagus and then like in the colon, and then like nowhere in between. So the management of someone that has Crohn disease, um, it's very much like on a case by case basis based on how severe their condition is when it's diagnosed, so on and so forth. But in general, since this is an inflammatory condition, you want to give immunomodulators, so like sulfasalazine, mesalamine, to manage and like tone down the immune hyperactivity, so to speak. You can also consider biologics or like antibodies, so like infliximab. And then if it's like, if they have fistulas and then they have like anatomic changes, then you can think about things like placing a seton or fistulotomy or a fistulostomy just to kind of address and whatever fistulas might be in place. Um, for any time they have a perianal abscess, right, like fever, fluctuant mass in the perianal region, you have to drain that and give antibiotics. But otherwise, this management um, regimen for Crohn's disease. Okay, so since we're talking about Crohn's disease, we'll talk about the other. Actually, before we get there, so there are also um, some important extraintestinal manifestations of Crohn or inflammatory bowel disease. Um, so if you can think about them, one of the very common ones is like an arthritis. So the joints can be affected. You can have ocular symptoms, so you can have like episcleritis, uveitis, and then you can have an effect on the blood. So you can have like anemia. Um, in this case, probably anemia of chronic disease. You might also have some iron deficiency anemia if you're not absorbing things in the GI tract, so on and so forth. Um, these symptoms tend to get better with management of IBD. So if you're giving the immunomodulators, so on and so forth, then these other extraintestinal manifestations will go down as well. So the way that I remember it is like these symptoms tend to improve with management. So if management, it's like a job, so you get a better job. Um, anyway, that's how I remember it. Um, Another thing that you can see in IBD or in Crohn is this other phenomenon called, or actually, I'm not going to call it yet. Um, you'll see someone that has like that they might have like minor skin trauma. Maybe they like bumped their knee on furniture or something, and then it develops into this really nasty rash. It's like irregular. It's an ulcer that has irregular borders. It's violaceous and it has like an undermined border where it's like if you took a little, I don't know, like a scalpel or like a probe or something, you could like stick it under their skin. Um, that's just pyoderma gangrenosum. Um, and the name of the phenomenon is pathergy. Um, so one important thing to consider for pyoderma gangrenosum is this isn't an infection per se. This is like a an immune response or an immune super response, so to speak. So you don't necessarily need to give antibiotics for this. If anything, it's like steroids and immunosuppression, because it's like a sterile lesion, not an infection. Okay. Um, so you might be thinking about where this is going next, since we were just talking about Crohn's. But let's say we have a different patient that has episodic abdominal pain and maybe they have bloody diarrhea. Maybe they have tenesmus, which is basically they feel like they have to go have a bowel movement very frequently, like all the time. Um, They might also have fever and weight loss over the course of a couple months. Um, One quick thing that I want to mention about the urgency, I remember learning that blood is basically a laxative. So if there's any blood in the stool, they'll be having a lot of bowel movements very frequently. So that's why they have tenesmus or urgency. Um, so the diagnosis in this case is ulcerative colitis or UC, which is also like the other flavor of inflammatory bowel disease. Um, the anatomic progression of UC is it starts in the distal rectum and then it progresses proximally through the colon, and like that's it. It doesn't go any further than the colon. Um, which is different from Crohn because Crohn can affect anywhere, like I said before, anywhere from the nose to the anus can be affected by Crohn. Um, anyway, the management of UC is kind of broken up into mild or severe, like based on the severity of the presenting patient. So, if they come to the office and like the symptoms are relatively mild and it's able to be treated in an outpatient setting, again, modulators like sulfasalazine, mesalamine, TNF alpha inhibitors like biologics, so on and so forth. One quick comment that I'll make on TNF alpha inhibitors is before you start these, you want to make sure that they don't have latent TB, so things like the PPD skin test, chest X-ray, things like that, because these TNF alpha inhibitors can, if they have latent TB, then if you start a TNF alpha inhibitor, then they can reactivate TB. So you obviously want to make sure that they don't have latent TB before starting TNF alpha inhibitors. Um, so let's say, for example, it's like a very severe flare and maybe they're admitted to the hospital. So you're seeing them on the inpatient basis and they have like really severe UC. The management gets a little bit different. You give them IV steroids, so like methylprednisolone, because their immune system is like so out of whack to the point where you need to tone it down with IV steroids. Um, and we'll get into some of the indications of a severe UC flare versus a mild flare. So you'll hopefully be able to make like a clinical decision between these two types. Um, Associated conditions of UC. This is one of my favorite mnemonics. It's very weird, but it's how I remember it. So there's a lot of C's. So obviously we're talking about ulcerative colitis or UC. So UC, PSC or primary sclerosing cholangitis, which is like little beads on the string in the bile ducts. So UC, PSC, toxic mega C or toxic megacolon, um, CRC or colorectal cancer, and cholangio-C or cholangiocarcinoma in UC. So put all together, it's UC, PSC, toxic mega C, CRC, cholangio-C in UC. So tons of C's. It sounds really weird, but it works because there's so many C's that it's easy to remember. Um, I think the most important ones to remember are like PSC, toxic megacolon, colorectal cancer, um, cholangiocarcinoma plus minus, but I threw that in there because it's another C. One quick comment that I'll make on colorectal cancer in UC and in Crohn's as well. Crohn's will develop or has an increased risk of colorectal cancer only if it affects the colon. Obviously, like if there's no inflammation in the colon, then it's not at an increased risk. Um, and what I learned is that the way in which colorectal cancer develops in patients with IBD is different from people that don't have IBD, right? Because in the general population that doesn't have IBD, that's the adenoma carcinoma sequence where you start this like little polyp and then it grows and then it mutates and gets out of control and then becomes colorectal cancer. In IBD, it's the chronic inflammation that is like the predisposing risk factor for colorectal cancer. So it's not the adenoma carcinoma sequence, it's just the inflammation that predisposes to colorectal cancer. Okay, so um, this is where we'll get into like recognizing severity of UC flares. So let's say, for example, the same guy or a similar guy that has like episodic abdominal pain, bloody diarrhea, urgency, maybe they have fever, weight loss. They also have, well, so this guy has a fever, a distended abdomen on physical exam, um, nausea, vomiting, diarrhea. This guy looks like really sick. compared to the person in the outpatient where they're like, yeah, I just have this abdominal pain, bloody diarrhea, so on and so forth. This guy in this case looks really sick. You get it because he's distended, and um, you get an abdominal X-ray, and it shows a massively dilated colon with loss of haustra, right? Like, if you think about the colon, it's got like these little kind of, it almost looks like septations, but it's not. Um, but in this case, if you look at the abdominal X-ray, it's like, normally you kind of have a colon that looks like this. Um, in this case, it's like there's no ripples or waves, I guess, which is the loss of haustra. The diagnosis in this case is toxic megacolon, right? Because it's a fever, distended abdomen, um, massively dilated colon, toxic megacolon. The management of this case, UC, toxic megacolon, as I said before, this is severe. So you give them IV methylprednisolone, you give bowel rest, so like NPO or so on and so forth. Um, and then you need to decompress it, right? Because it's super distended, you need to decompress it. And because they're febrile, it might be infected, so you give antibiotics. Um, let's say, for example, a similar patient comes in and you do an abdominal exam and they're peritonitic, right? So they have like a bored, like a rigid abdomen, they have rebound tenderness, and then on vitals, they're like hypertensive, not tachycardic, hypotensive, so like hemorrhagic shock. Um, they need a colectomy in this case. So, you might see a question where you have a picture like toxic megacolon, and then it's like, which of the following is the next step? And you'll see like these options like for IV methylprednisolone, and then you'll also see the option for a colectomy. You only need to do a colectomy like at that moment if they have peritonitis or if they have hemorrhagic, like if they're unstable, then you need surgery. Otherwise, um, you can be less invasive. Um, so what can also help with like knowing when to do a colectomy in UC, or there are some indications for a colectomy in UC. So number one, as we were just talking about, is toxic megacolon. Number two, I've seen like if they have active disease for longer than 20 years. So if they were diagnosed like 25 years ago, you might want to start thinking about a colectomy. Um, if they've had multiple hospitalizations for UC flares, and then if they've been on long-term immunosuppression or steroids, that's where you also kind of want to start going down the road of getting a colectomy to manage UC. And then if they have like nutritional deficiencies, right? Like if they're not absorbing vitamins, if they're not getting adequate nutrition, if they're losing weight and they're like cachectic, you'll want to consider a colectomy. Okay. Um, so continuing with IBD, let's say, for example, um, like a newly diagnosed IBD patient gets discharged. So, they get managed. Now they're doing pretty well and they get discharged and it's a new diagnosis of IBD, some flavor of IBD. So what do we tell them about preventive screening? Right? Because earlier we were talking about colorectal cancer. So you obviously want to start thinking about colorectal cancer. So you want to talk to them about getting colonoscopies every 1 to 2 years, starting 8 years after their symptom onset, not after their diagnosis. So obviously you want to get the colonoscopies to screen for colorectal cancer, and the frequency is up, right? Because normally it's every 10 years if they have no risk factors, but since they have a risk factor, you get them more frequently. And then the age may start earlier, based on when their symptoms started. So let's say, for example, there's like a previously healthy 20-something-year-old patient that gets a new diagnosis of IBD, but they've been having symptoms since they were 20. Then their first colonoscopy would be at 28 years old, right? Because their symptoms started at 20, 8 years later, they're 28. That's when they get their first colonoscopy. Um, so do all patients with Crohn's disease follow this guideline? So this guideline is more for like a universal blanket statement for patients with UC or ulcerative colitis, right? Because it's affecting the colon. But if a patient has Crohn, they don't always need to get these colonoscopies at this frequency, provided that the patients with Crohn follow this guideline if their disease affects the colon. So if they have um, if they have symptom onset in the colon, then 8 years later, then they need to start getting colonoscopies, because their colon has started to be affected. But if they don't have any disease affecting the colon, then they don't need colonoscopies just yet. Um, One other thing that I'm just now remembering for Crohn, one distinguishing feature. So I know earlier I said Crohn is associated with fistulas. Um, in addition to fistulas, you can also see strictures in Crohn disease, or like narrowing of the um, GI tract, whereas you don't necessarily see that in UC. Um, okay, before I go on to colonoscopy indications, another thing that I'm remembering for Crohn disease, I don't necessarily think it's as high yield for step two, but you can also remember the Crohn disease is like associated with the cobblestone, mucosa, transmural inflammation, things like that in Crohn. So like, if you think about, you can rhyme it with the features, right? So Crohn, cobblestone, um, it forms like granulomas. So Crohn, cobblestone, granuloma, um, and then it like punches an O through a wall, so it's transmural, and that's how you make fistulas. Um, Again, I don't think that's as important for step two, but anyway, in case you want to know. Okay, so general colonoscopy indications. Like I said before, and as we talked about um, in the family medicine episode, if you have no risk factors like at all, you're just a general person with no family history, no personal history of any like pre-existing conditions, you get your first colonoscopy at 45, and then you get them every 10 years, assuming each colonoscopy is normal. Um, if you have a first degree relative that has a history of colorectal cancer, you take their age at diagnosis, you subtract 10, and then that's your start age, unless if that comes after 45 years old. So let's say, let's say for example, someone's mom had colorectal cancer diagnosed at 60. 60 minus 10 is 50, which comes after 45. So they still start colonoscopies at 45. Compare that to someone who had a dad that was diagnosed with colorectal cancer at 40, or sorry, at 50. So dad was diagnosed with colorectal cancer at 50. 50 minus 10 is 40. In that patient, they start getting colonoscopies at 40. So whatever comes first. Um, Relevant to the surgery shelf, anytime there's a suspected lower GI bleed, that's usually where you want to consider getting a colonoscopy just to see where the bleed is coming from. So if there's like bright red blood per rectum, well, first things, if there's bright red blood per rectum, you want to rule out hemorrhoids. So you can just do like a rectal exam and see if there's any bright red blood there. Um, but otherwise, if there's like melena or um, you rule out hemorrhoids, then you want to consider a colonoscopy to see where the bleed is coming from. I'll talk about more like GI bleed stuff in the next surgery episode, or maybe an IM. I don't know. Anyway, so continuing with colon stuff, um, there are, this is like a little bit lower yield of a detail, so I'll just kind of skim through this, but there are pre-malignant and then like non-pre-malignant colon polyps, and then in order of the highest risk to the lowest risk of becoming cancerous. Okay. So the premalignant ones include things like familial polyps, familial multiple inflammatory polyps, villus polyps, and adenomatous polyps. Um, these two, like the villus and the adenomatous polyps, come up pretty frequently. The villus one is higher risk than adenomatous polyps. So if you see villus polyps on a colonoscopy, you might want to get an like a sooner follow-up colonoscopy versus an adenomatous polyp. And the way that you remember is like villus sounds like villain, so it's more premalignant or higher risk. Um, you won't necessarily, I don't remember coming across questions that ask you like how many years from now is the next colonoscopy. I think that's a little more specified than you need to know. Um, so in contrast to premalignant colonic polyps, there are non-premalignant oh my God, I'm tripping over my words. Non-premalignant colonic polyps include things like Poitiers disease, juvenile colonic polyps, isolated inflammatory polyps, and hyperplastic polyps. The one unique thing about Poitiers is someone is diagnosed with Poitiers, um, you start colonoscopies at 8 years old. So you can remember that as like Poitiers, Pates Jaegers. That's when you start colonoscopies. Okay. Another thing that, yeah, colon is very high yield for surgery. So we're going to continue with colon. So there's an older patient that has a history of chronic constipation. They have abdominal distension. They have like some abdominal pain. They have bloating. They're also constipated. So they have chronic constipation and they're constipated this time, plus or minus nausea vomiting. Like that's not a required feature. So how do you want to evaluate this patient? You want to get a KUB or an abdominal X-ray. That is the same thing. Kidneys, ureters, bladder, I think is what it stands for, but that's just an abdominal X-ray. The diagnosis in this case is sigmoid volvulus. And we'll see a picture of an abdominal X-ray of sigmoid volvulus. The risk factor that's associated with sigmoid volvulus is chronic constipation. So that can predispose for sigmoid volvulus. The management of sigmoid volvulus is endoscopic detorsion. So this by itself doesn't necessarily need open surgery per se. You can just go in with an endoscope and detors it that way. So let's say, for example, the patient, this older patient that has sigmoid volvulus, they come back with the same symptoms. So they have a repeat sigmoid volvulus. So what do you do next? In this case, since you've already done the endoscopic detorsion and it keeps coming back, in this case, you want to consider like a colopexy or a sigmoid colectomy just to prevent it from happening again in the future. So you can like, colopexy is like anytime you see pexy, it's like an attachment or like stick it somewhere. So you can like attach it to the right lower quadrant or left lower quadrant and prevent it from acting up again, or you can just take it out. Let's say, for example, there's a patient that has sigmoid volvulus, but they're hemodynamically stable and or they're peritonitic. In this case, you just screw the endoscope, you go straight to surgery, even if it's their first time having sigmoid volvulus. So this is kind of one of those situations where, yes, you know that the diagnosis is sigmoid volvulus, and then you think, well, you do an endoscopic detorsion for sigmoid volvulus, but the fact that they're unstable and or peritonitic, this is an indication for surgery, so that trumps. Okay. Um, we were just talking about sigmoid volvulus, so we'll kind of stay around in the colon. We'll talk about a different kind of volvulus. There's a young adult with no medical history, like previously healthy. They present with abdominal pain, episodic cramping, maybe nausea, vomiting. They haven't had a bowel movement in a few days. Vitally, they're stable. And then on physical exam, their abdomen is distended and tympanitic. How do you want to evaluate this patient? Very similar to the last one, you get a KUB or an abdominal X-ray. The diagnosis in this case is cecal volvulus. So, if you're thinking sigmoid volvulus is the left lower quadrant, cecal volvulus is the right lower quadrant. Um, the management of this case for cecal volvulus is surgery. So, for sigmoid volvulus, you start with the endoscope, but for cecal volvulus, even though this guy is stable, you still do surgery for cecal volvulus. Um, what if you get an abdominal X-ray and there's pneumoperitoneum on the abdominal X-ray? You get an X-lab. That's like pneumoperitoneum means go straight to the OR. So in this case, like for cecal volvulus, um, they get surgery either way, but um, pneumoperitoneum is like really you get surgery. Um, so here are some pictures of sigmoid volvulus, cecal volvulus, and then pneumoperitoneum because I didn't talk about pneumoperitoneum in the last episode, so I wanted to talk about it here. So starting from left to right, sigmoid volvulus is the first one you talked about. So, you probably hear about the coffee bean sign. So this picture really looks like a coffee bean. Another way that you can remember sigmoid volvulus, um, right, the sigmoid colon is in the left lower quadrant. So if you take this like marking here and draw an arrow down, it's pointing to the left lower quadrant. So sigmoid volvulus. Um, Okay. Cecal volvulus is very similar. It's a little more difficult to make out the coffee bean, but maybe it goes like this a little bit, and then here's the thing here. Um, but if you take this mark and draw it all the way down and make an arrow that's pointing to the right lower quadrant, which is where the cecum normally sits. So cecum versus sigmoid colon. And then here's pneumoperitoneum. So free air under the diaphragm is the indication for an X-lap in any case. Like if there's abdominal trauma and then they have pneumoperitoneum and you see the free air under the diaphragm, that's an indication for XLAP. And then like as we were talking about for cecal volvulus, if there's pneumoperitoneum, again, XLAP, like go to surgery. Even if like sigmoid volvulus had pneumoperitoneum, they get surgery. And the reason why this is so important to keep in mind is anytime you have pneumoperitoneum and like abdominal pain and you're peritonitic, so on and so forth, that means or it's possible that somewhere in the abdomen there has been a bowel rupture or a perforation. So, perforation, then air leaks into the peritoneum. Then when you get an upright KUB, you see pneumoperitoneum, which is bad. Okay. Um, I think I'll finish with hepatobiliary stuff and then we'll come back to more stuff in subsequent episodes, but we'll talk about like hepatobiliary stuff. So there's a patient that has chronic alcohol use and then they come to the emergency department because they've been throwing up blood or hematemesis. Vitals are here, temperature is 37.5, heart rate is 110, blood pressure is 95 over 65. And you do a really quick focused physical exam and they have hepatomegaly, so you can like palpate the liver edge. They have spider angiomata, they have palmar erythema, they might also be jaundiced. So they're bleeding, so that's probably the chief concern here. So you want to think about where the bleed is. Um, So in this case, this is likely a bleeding esophageal vein from like a varicose vein in the esophagus, likely in the setting of cirrhosis. So the reason why this kind of all puts together, right, this patient has chronic alcohol use, they have hepatomegaly, spider angiomata, pulmonary erythema. This is stuff that you'll see like in IM that's consistent with cirrhosis. And then they're throwing up blood, which mean, so in cirrhosis you can have like blocked up venous drainage from the esophagus. So then you can have varicose veins in the esophagus. Those can rupture and you can get hematemesis. Um, okay, so esophageal bleed. What's next? How do you manage this patient? Um, First, I've seen you get an EGD or an esophagogastroduodenoscopy with sclerotherapy versus variceal banding to stop the bleeding, right? Because they're bleeding, they're throwing up blood, you want to stop it. So you do one of these options. You also want to consider doing things like a somatostatin analog, like octreotide, to manage the bleed. You can give things like vasopressin or ADH analogs to like manage the bleed. And if the patient doesn't respond to like these initial options, you get a TIPS or a transjugular intrahepatic portosystemic shunt um, to like that's like a second line management of the esophageal bleed. One important thing to consider for contraindications for TIPS is if they have heart failure, because otherwise the blood just goes like straight into the heart. So if the heart's not working too well, then you might make heart failure worse. Um, TIPS also doesn't help with like hyperammonemia. So if they have like the asterixis and they have like cerebellar ataxia, so on and so forth, um, getting a TIPS won't necessarily help. If anything, it might make it worse because there's less blood going to the liver. Therefore, there's less ammonia going to the liver to get metabolized. So it stays in the system longer. You can have neurotoxicity. Okay. Um, so let's say, for example, this patient gets managed, their bleed stops, and then they're discharged. From a screening standpoint, what do you want to start doing after they're diagnosed? With cirrhosis, you get an abdominal ultrasound every 6 months or so to screen for hepatocellular carcinoma. Okay, continuing with hepatobiliary stuff. Let's say, for example, a patient has postprandial episodic right upper quadrant pain that radiates to the right shoulder. So, they have a meal and then they have right upper quadrant pain, and then they're also like, oh, my shoulder hurts. Um, how do you evaluate this patient, right? So it's like evaluate diagnosis management. So you evaluate this patient. So first you start with vitals, right? Like, if you're taking an oral exam, it's like, well, you want to get their vitals. So you get their vitals. They're afebrile, so you're fine. What imaging do you want to get for this patient? You get a right upper quadrant ultrasound to look in the gallbladder. If the right upper quadrant ultrasound is negative, then you can kind of go, that's when you could start going down the route of getting a HIDA scan. Um, and the way that I remember this is like, you get the right upper quadrant ultrasound first, and if you don't see anything, then whatever's causing the pain could be hiding or HIDA in the liver or somewhere in the bile duct. What blood tests do you want to get for this patient? I mean, usually you get like a CBC, like routine labs. Let's say you get a CBC and there's no leukocytosis. You can also get like an LFT, liver function tests, and the results of the LFT might actually tell you where the pathology is. So if the LFTs, like the AST, ALT, are elevated, um, then you can think that the pathology is in the common bile duct because then there's obstruction of flow out of the liver, so then it sticks around in the liver, um, can cause liver damage, which therefore causes an elevated LFT. If the LFTs are normal, um, the pathology is likely in the gallbladder or in the cystic duct, so it hasn't yet reached the point where it's blocking bile flow from the liver. Um, so we did all of this evaluation and stuff for which, I mean, if you think about this, this is a pretty straightforward diagnosis. This is just biliary colic. Um, and we'll talk about like the other kind of the associated thing that people can think about with right upper quadrant pain, like cholecystitis. This is not cholecystitis because the patient is afebrile and they don't have any leukocytosis. So there's no infection, so there's no itis. It's just biliary colic. It's just pain because of a gallstone that's either in the gallbladder or in the cystic duct or in the common bile duct. And then that's what's causing the pain. And that's why you look for it on a right upper quadrant ultrasound. Or if it's hiding in the liver, you get a HIDA scan. Or if it's in like any of the bile ducts that you can't see with a right upper quadrant ultrasound. The management of biliary colic, you can make recommendations for a low-fat diet. But let's be honest, like you can make the recommendation for it, but it's much harder to stick to that regimen in real life. You can give antiemetics if they're like nauseous or vomiting. Um, you just give like analgesics to help with the pain. Um, so you don't necessarily need surgery to manage biliary colic. You can just manage it out as an outpatient. Um, but if you want to talk about surgery, the surgical approach for a gallbladder stone, so if there's a stone in the gallbladder, you can get like an elective laparoscopic cholecystectomy or a lap chole to take out the gallbladder or to take out the gallbladder and then therefore get rid of the stones, right? Because statistically, people that have biliary colic are very likely to have biliary colic again. So if you just take out the gallbladder, then they're not going to have it again. Um, let's say, for example, it's not in the gallbladder, but it's in the common bile duct. So like, right, if you think about the liver like this, and then like the ducts come down, and then the little gallbladder is here, here's the cystic duct, and then it joins with the common bile duct, and then like, whatever, here's the pancreas. It does that little thing, and then it goes into the duodenum, right? Like if there's a stone in the common bile duct, it's like here or so, so then all that flow is obstructed. You get an ERCP or the endoscopic retrograde cholangiopancreatography. There's a mouthful, right? Because you just like go in the mouth, down the esophagus, into the stomach, into the small intestine, and then you like stick this little thing into the common bile duct. You can like take out the stone, you can put a stent in, things like that. However, after you do the ERCP, since the gallbladder is still there, there's a chance that it'll produce more stones, and then they can put a stone into the common bile duct again. So after the ERCP, you will probably consider an elective lap chole just to prevent that from recurring. Okay. Um, so here, very similar to the last patient, let's say they have postprandial episodic right upper quadrant pain, radiates to the right shoulder. But this time they have like a new episode. They had like a big dinner and then they have right upper quadrant pain and it's still there. And then they start getting febrile. And then you do labs, and on the labs, they have leukocytosis. So okay, the evaluation of this is very similar to biliary colic. So you get the imaging, you get the right upper quadrant ultrasound, you get basic labs, so on and so forth. But this is not biliary colic, it's cholecystitis. So The fever and leukocytosis means that there is an infection or inflammation, which therefore earns it the title cholecystitis, because of the inflammation. Um, the management of cholecystitis, you make them NPO, right? Like you don't, if it gets bad when they're eating, you don't want to make them eat or drink anything. They also might need surgery, so that's why you make them NPO. You give them IV fluids, you give them IV Zosyn or piperacillin tazobactam, um, or IV antibiotics. And then I've seen you give them a lap chole before they're discharged. In real life, recommend people do all kinds of different approaches, but like this general management approach is a good place to start. Okay, so continuing with right upper quadrant pain, that radiates to the right shoulder. Radiates to the right shoulder because there's like referred pain. So anytime there's like irritation in that area, it'll just be referred to the right shoulder. Anyway, so right upper quadrant pain, fever, leukocytosis, we've seen this before, but in this case, we have an elevated alk phos, plus or minus altered mental status, plus or minus hypotension. They might also be jaundiced, so a little bit more severe than we've seen before. Let's say they present to the emergency department and they're altered mental status, so you can't really get too much of a history from them. Um, so the evaluation of this patient, as we've seen before, you get a right upper quadrant ultrasound. Um, the diagnosis in this case is ascending cholangitis. Um, I think I have it, maybe. Um, there's like I think I'll talk about this in a couple points, but if not, I'll come back to it. But so this is ascending cholangitis. The management of ascending cholangitis, you give them antibiotics, and you do an ERCP, and then you get a lap chole. So this is very similar to um, gallstones that are in the common bile duct. So the way that this happens is like, you have, so I'll draw the little, so here's the liver, and then gallbladder, and then here's the common bile duct. Here's the cystic duct, joins the common bile duct, not anatomically to scale. Um, so you have a little stone in the gallbladder goes into the cystic. It gets blocked in the common bile duct, and because there's blockage, fluid doesn't move. And anytime you don't have fluid moving, then you can get infection, right? Bacteria love static fluid, things like that. So you have blocked fluid here, and then bacteria can ascend. So here's the pancreas, and then there you go. So you have bacteria in the small intestine that can ascend through the bile duct, like the common bile duct, and then it can get into the gallbladder, it can get into the liver, so on and so forth. So it's an infection. You give them antibiotics. You do an ERCP to get rid of whatever is blocking bile flow in the common bile duct. Um, and then you get a lap chole, um, to prevent this from happening again. Um, okay, so before I talk about this, um, the next condition, one important thing to consider for um, ascending cholangitis is the Charcot triad and Reynolds pentad. I'm not sure why it didn't. I thought I added it, but it's not here. So, um, f- right upper quadrant pain, jaundice, and fever. Those three features are Charcot's triad. And then if you have like altered mental status and hypotension, that's Reynolds pentad. Um, so those are like the buzzwords or the features that you want to consider when you're thinking if somebody has ascending cholangitis. So like as you're reading a test vignette and you see these kind of features, you'll want to think ascending cholangitis. Okay, so let's say um, there's a patient that has similar to the last one, fever and leukocytosis, but in this case, they have right upper quadrant tenderness. Um, so these three features altogether um, might suggest like acute cholecystitis, right? Because you can have the Murphy sign where you're doing right upper quadrant palpation and they stop breathing and they're like, oh, that really hurts. Um, so these features by themselves won't necessarily nail the diagnosis, but you get the right upper quadrant ultrasound and you see this like hypoechoic lesion in the liver, like a well-circumscribed hypoechoic lesion. Um, so this is a pyogenic, because they have a fever, liver abscess, right? Because you have the abscess, the hypoechoic lesion in the liver. This can be a like an associated complication of ascending cholangitis, right? Because like you have the infection of the common bile duct, and then that can ascend even further into the liver, and then it can set up shop in the liver, and then it can cause an abscess. The management of a pyogenic liver abscess, it's an abscess, so you have to drain it. So you do percutaneous drainage, and then because it's also an abscess, like after you drain it for source control, you give them antibiotics to get rid of whatever lingering bacteria there are. So in this case, I mean, the recommendations changed, but a good regimen to think about is a third generation cephalosporin like ceftriaxone, and metronidazole, right? You get GAP on the metro. Okay. So I think I'm going to stop here just because I think this episode's getting a bit long, but fortunately there's a ton of content that I can keep covering in future episodes. So hopefully the next time you guys see an episode on surgery, it won't be super long, it won't be super far from now. As always, I look forward to seeing whatever you guys have for suggestions or feedback on how to improve this going forward. Um, if you like the style that this video took, let me know. Otherwise, let me know what I can do to make this as helpful for you guys. I mean, this is just my passion project. I like making this. So whatever works best for you guys, I'm happy to experiment with. So with that, with that being said, if you are studying for your surgery shelf, best of luck. If you have surgery oral exams, my school did. Um, Good luck studying for the oral exam. If you're studying for step two, good luck with step two. It'll go very well, I promise. Um, but with that being said, take care. Thank you so much for watching.